I'm going to say something that could get me in serious trouble with some of my colleagues. There are surgeries being performed on patients over 65 every single day in hospitals across this country. Surgeries that I, after 15 years of specializing in senior health, would fight hard to avoid for anyone in my own family. And the most alarming part, the patients consenting to these procedures have no idea what the real numbers look like on the other side. Stay with me, because what I'm about to share isn't just information, it's a framework that could protect your independence, your mind, and your life. In the next few minutes, you're going to understand something that most doctors never take the time to explain in a standard 12-minute appointment. You're going to learn why the body over 65 responds to surgery in a fundamentally different way than a younger body does. You're going to hear real stories, not to scare you, but to prepare you. And you're going to walk away with concrete questions you can bring to any doctor's office the next time a surgical recommendation lands on the table. My name is Dr. Gregory Holt. I've spent more than 15 years working exclusively with patients over 60, first as a hospital-based internist, then as a geriatric medicine specialist. I've sat beside thousands of seniors navigating some of the hardest decisions of their lives. I've read the studies, I've seen the outcomes, and I've had conversations in hospital corridors that patients never get to hear. That's what this channel is for. Before we go any further, I want to be clear about something important. Everything I share here is educational. It is not a substitute for professional medical advice. Every person's medical situation is unique, and nothing in this video should replace a conversation with your own physician. What I'm giving you today is knowledge, the kind of knowledge that helps you ask better questions and make more informed choices. Please use it that way. Now, let's talk about what's really happening. The first thing you need to understand is why the over 65 body and surgery are a fundamentally different equation than most people, including many surgeons, acknowledge openly. Think about it this way. Imagine you have two cars. One is a 2010 model, well maintained, but with 140,000 miles on it. The other is a brand new 2024 model fresh off the lot. You take both to the same mechanic and subject them to the same repair process. Same tools, same procedure, same recovery garage. The new car bounces back in days. The older car, it might need weeks. Some parts that were stressed during the repair don't fully recover. Other systems that were already working close to their limit get pushed over the edge. That's not a flaw in the older car, that's physics, that's reality. Your body after 65 has lived a full, rich life, and it carries that history in every cell. The biological reserve that a 40-year-old takes for granted, the rapid immune response, the fast muscle regeneration, the cognitive resilience after anesthesia, that reserve narrows with age. Not because you're weak, because you're human. And here's what makes this so critical. Our entire surgical system, the protocols, the post-operative timelines, the recovery expectations, was largely built around younger patients. When you apply those same protocols to a 72-year-old, the gap between what the system expects and what the body can actually deliver can become dangerous. I want you to keep that image in mind throughout this entire video because it explains nearly everything I'm about to tell you. Comment the word cars right now if that analogy clicked for you. I genuinely want to know how many of you are tracking with this. Let me tell you about a patient I'll call Eleanor. She was 73, a retired librarian from Ohio. Sharp, funny, organized. The kind of woman who brought a typed list of questions to every doctor's appointment. She developed moderate knee arthritis and was told by her orthopedic surgeon that knee replacement was her best option. She was healthy. Her labs were excellent. Her cardiologist cleared her without hesitation. Eleanor had the surgery. Technically, it went beautifully. But on day 2 post-op, Eleanor became disoriented. She told the nurses she needed to get back to the library because the morning shipment of books had arrived. By day 4, she didn't recognize her son when he walked through the door. What Eleanor experienced is called post-operative delirium, and it's one of the most underreported, misunderstood, and devastating complications in elderly surgical patients. A landmark study published in the New England Journal of Medicine found that up to 50% of patients over 70 experience some degree of post-operative cognitive dysfunction after major surgery, not temporary grogginess, not normal anesthesia fog, measurable documented cognitive decline, still present 6 months after the procedure in a significant percentage of cases. Here's why. Anesthetic agents accumulate differently in an older brain. They interact with the medications most seniors are already taking. They disturb neurotransmitter systems that don't have the same elastic resilience they had at 45. Every additional hour under general anesthesia after age 70 is a variable that increases risk. Eleanor spent 3 weeks in the hospital instead of 5 days. She went to a rehabilitation facility instead of home. 8 months later, she still hasn't fully returned to the person she was before she walked into that operating room. The knee was repaired, but Eleanor paid a price that nobody showed her in the pre-operative brochure. If you know someone whose personality or memory changed after a hospital procedure, comment Eleanor below. I want to understand how widespread this experience really is. Let's move to the second thing I need you to understand, because this one surprises people every time. The hospital itself, not just the surgery, can be a serious risk factor for seniors. Picture what a hospital environment actually is for someone over 70. Fluorescent lights that never go off, beeping machines at 2 a.m., nurses doing vital checks every 2 hours through the night, an unfamiliar bed, unfamiliar sounds, a ceiling you've never stared at before. No sunlight cues, no normal meal schedule, no natural rhythm. For a 35-year-old, this is inconvenient and exhausting. For a 75-year-old, it can be genuinely catastrophic. The human brain over 65 depends heavily on circadian rhythm, that internal clock that tells your body when to sleep, when to repair, when to be alert. Disrupt it severely and suddenly enough, and you can trigger a cascade of disorientation that has nothing to do with the surgery itself. The medical term is hospital-acquired delirium, and it affects an estimated 1 in 3 hospitalized patients over the age of 70. I had a patient, I'll call him Harold, who came in for a routine procedure on a Monday. By Wednesday, he was asking the nurses what city he was in. By Friday, his daughter was making phone calls about long-term care options. Harold had never had a cognitive issue in his life. The surgery hadn't touched his brain. The hospital had done it on its own. This isn't rare. The research from Johns Hopkins estimates that hospital-acquired conditions, infections, delirium, muscle loss, falls, medication errors affect nearly 1 in 4 elderly inpatients. These are conditions that didn't exist before admission. So before you or a loved one consents to an elective surgery that requires a multi-day hospital stay, ask this specific question: what is your protocol for preventing post-operative delirium in patients my age? If the team doesn't have a specific detailed answer that tells you something important, keep watching, because the next point is the one that most people never hear until it's too late. Point 3. Muscle loss during hospitalization is faster and more permanent in seniors than almost anyone realizes. Here's a number that stopped me cold the first time I read it in the Journal of the American Geriatric Society. Hospitalized patients over 70 lose between 1% and 5% of their total muscle mass every single day they are bedridden or sedentary. Every single day. Compare that to a 45-year-old who might lose 0.5% daily and rebuilds it relatively quickly once they're back on their feet. For a senior, losing 3% of muscle mass per day for 10 days means losing nearly a third of functional strength. And unlike in younger patients, that muscle doesn't reliably come back. I want you to imagine a retired contractor. Let's call him Vincent, 76 years old, still doing his own yard work, still carrying his own groceries. He goes in for a standard hernia repair. Surgery is fine. He's in the hospital for 6 days. By the time he gets home, he can't climb his own stairs without holding the railing with both hands. He can't lift a bag of mulch. He can't do the things that made him feel like himself. The hernia was fixed, but Vincent lost something that no amount of physical therapy fully gave back. This is why, for any recommended surgery, I urge patients and families to specifically ask, what is the plan to keep me physically active during recovery? Will I have access to daily physical therapy during my hospital stay? What does muscle loss prevention look like for someone my age? If the surgeon looks puzzled by the question, ask for a geriatric consultation before you sign anything. Point 4. The cascade effect, and why one complication rarely stays one complication. I describe this to patients as falling dominoes. When you're young and healthy, you knock over one domino and it hits the floor. Done. When you're over 70, that first domino hits a second one, which hits a third, which hits a row of 10 more, and suddenly you're managing 5 conditions that didn't exist when you walked in. It works like this. You have surgery, you develop post-operative pain, which limits your mobility. Limited mobility leads to a blood clot in your leg. The blood clot requires blood thinners. The blood thinners cause internal bleeding. The bleeding requires a transfusion. The transfusion triggers an immune reaction. Meanwhile, you're not eating well, so wound healing slows. The wound doesn't close properly, and now there's an infection. The infection requires IV antibiotics. The antibiotics disrupt your gut bacteria, causing severe diarrhea. The diarrhea causes dehydration. The dehydration strains your kidneys. And at no point along that chain did anyone do anything wrong. The system worked exactly as designed. The cascades happened because the body over 70 has fewer buffers, fewer reserves, and less margin for error when stress compounds on stress. I've seen patients come in for a scheduled outpatient procedure and still be in the hospital 4 months later. Not from surgical complications, but from the cascade their body couldn't stop once it started. This is why the decision to operate is never just about the surgery. It's about your entire physiological reserve and your body's capacity to absorb shock. Now let's talk about point 5. The one that actually gives you power in this situation. Alternatives exist that most patients are never told about. And here's why they're not told. The surgical system is not designed to present alternatives. Surgeons are trained to operate. Hospitals generate revenue from procedures. Insurance pathways favor intervention. That's not a conspiracy. It's just how the system was built. But the alternatives are real, they are studied, and for many conditions in seniors, they are equally effective or carry substantially lower risk. Let me tell you about a patient I'll call Frances. She was 71, active, sharp, living alone very successfully. She developed significant spinal stenosis and was referred to a spine surgeon who recommended a fusion procedure, a major multi-level surgery with a 12-week recovery at minimum. Frances was nervous but was essentially told this is the path forward. She called my office before signing the consent form. We sat down together. We went through her priorities, staying independent, keeping her garden, being mentally sharp for her grandchildren. We talked about her frailty index score, a validated clinical tool that calculates actual surgical risk for older patients. We discussed what the peer-reviewed literature says about outcomes for her specific procedure in patients her age. Then we built an alternative plan, targeted physical therapy with a specialist who focuses on seniors, epidural steroid injections for acute pain management, an anti-inflammatory dietary protocol, home modifications, aquatic therapy. That was 2 years ago. Frances is 73 now. She still has stenosis. The imaging hasn't changed, but she's still gardening. She's still independent. She still hosts Sunday dinners. She made an informed choice, and that choice is working for her. Would surgery have given her more relief? Possibly, but at what cost to her cognition, her muscle mass, her cascade risk? She decided the trade-off wasn't worth it, and she had the information she needed to make that call. That is what I want for every single person watching this video, not to avoid surgery at all costs, but to make a real, informed, value-based decision, not just a fear-based one, and not just the default path the system puts in front of you. Comment Frances if you or someone you love has successfully managed a condition conservatively that a surgeon wanted to operate on. I read these comments and they matter. Here's your rapid recap because I want you to walk away with this locked in. 1. Anesthesia and elderly brains are a serious combination. Post-operative cognitive decline is more common than most patients are told. 2. The hospital environment itself carries real risk for seniors. Delirium, infection, sleep disruption, and disorientation happen even when surgery goes perfectly. 3. Muscle loss during hospitalization after 70 is rapid and often permanent. Physical recovery is a second battle fought on top of the surgical one. 4. The cascade effect means one complication triggers more. The older the patient, the fewer buffers exist to stop the chain. 5. Alternatives exist. Ask for them explicitly. Demand them if necessary. Get a second opinion from a geriatric specialist, not just another surgeon. Before any major surgery, ask your doctor to calculate your frailty index. Request a baseline cognitive test. Ask specifically what the non-surgical alternatives are and why they're being ruled out. Ask for the realistic worst-case outcome in percentage terms. And if you don't get honest, specific, numbers-based answers, get a second opinion. You are not being difficult when you ask these questions. You are being exactly the kind of informed patient who gets better outcomes. If this video gave you something real to work with, a question you didn't know to ask, a framework you didn't have before, consider subscribing. Every week I bring conversations like this one to the people who need them most, not to sell you anything, just to make sure you walk into every medical appointment a little more equipped than you were before, because that ultimately is what this is all about.